All right, so other drips. So we talked about vasopressors. We'll talk about insulin coming up. We'll talk about sedation and such. But these are things that don't fit under insulin or sedation or paralytics. So there's everything else. So we got our antiarrhythmics. We got anticoagulants. What's some anticoagulants we usually infuse? We got some heparin. We got, if they're heparin allergic, we can give argatroban. So there's other agents we can give. And we got some inotropes to continue our discussion with our vasopressors, right? We have inopressors, inodilators. So we do have some inotropes. And these actually don't require any kind of ICU care. You can have these outside the ICU. So like what if I told you like cardizem, amio, dobutamine, they don't really require the ICU. If you're titrating dobutamine and milrinone, which are your inotropes in the ICU with a SWAN, of course they need ICU, right? But usually you have patients that get their cardiogenic shock gets fixed, or they have to remain on a dose of dobutamine, for instance, and they can then leave the ICU on that dobutamine as long as they don't have, the SWAN Gans catheter, etc. Right? And sometimes patients come from outside the hospital with the dobutamine pump, right? And it's like, oh, they got to go to ICU. It's like, what's going on, right? So they just said they have a pump. That's their thing as an outpatient, right? Why would they need ICU at this point? But if they were to get worse, more hypotensive, because we know dobutamine, as we'll learn, will cause this hypotension. It's an inodilator, all right? And then we got our GI drips. So in red is appropriate, right? We got Protonix infusion, and we have a Sandostatin infusion. You should never see a Protonix infusion. You should see Protonix BID because there is no difference in efficacy. So it frees up a line for you as well, right? Because when you're infusing all these things, you need multiple ports, you need a central line sometimes, and then you have like poor access, and you're like, what do I do? What do I stop? It's like, well, I can stop the Protonix drip and just give a Protonix push BID. Right? When a Protonix is just given daily, it's just for prophylaxis. When you give a BID, then it's for like a GI bleed. Okay, you can't do that with Sandostatin. Sandostatin's going to be given IV. There is a sub-Q form, but if they're like in shock state, are they really going to respond to a sub-Q? Probably not, right? And then vasopressin. We said vasopressin is for GI bleeds, right? And that's where you're titratable vasopressin. So obviously we need ICU at this point, right? As a really sick patient. And then we're going to talk about some other drips that you titrate in the ICU. That'd be your antihypertensive drips. You're never going to have someone on the floor just on nicardipine to lower the blood pressure. Never going to be someone on the floor with a beta blocker infusion, right? Esmolol, for instance, or nitroprusside even. You should never be on nitroprusside either. Nitroprusside's a really, really toxic drug, right? It's like a last-ditch effort. All right, so these are our drips that don't need the ICU, and a few at the end where I didn't know where else to fit them, and this made the most sense. All right, so antiarrhythmics. So we got diltiazem and we have amiodarone. Those usually are our go-to agents that are going to lower the heart rate, right? Yes, they lower the heart rate, but they also change the intervals a little bit and will hopefully suppress any kind of tachyarrhythmias. One of them works on the atria. Which one is that? It works on supraventricular tachycardia. So we have all of this AFib activity happening, right? It's an AV node suppression agent, right? So it's going to suppress the AV node and not allow these impulses to get through, right? It's only going to let one impulse get through. Hopefully it's the SA node, but it's only let one little impulse through, right? Or maybe two impulses through. If it doesn't let any impulses through, you have too much diltiazem infusing, right? So that's a bradycardia, because these are for tachyarrhythmias, right? So an AFib RVR or a SVT would probably, PSVT would probably give something else, but definitely a tachyarrhythmia, like an A flutter that's too fast. Yeah, we're going to start blocking the AV node and help suppress the amount of P waves they're getting through this AV node, right? So diltiazem or cardizem is going to work only on atrial rhythms, only on supraventricular rhythms, right? Rhythms that come from above the ventricle, and that makes sense because it only works on the AV node and SA node a little bit, right? So our dose, you usually bolus it in to get someone's heart rate under control, and then sometimes they'll let it slide and see if it works. If it doesn't work, then they'll give another bolus, and then they'll start a drip, right? And again, it has 3 titrations. I mean, it's arguable that this could be used on tele if it's some kind of little education program. You can say, hey, you're on cardizem, you got 3 options. Heart rate less than 100, go down by 5. Heart rate less than 100 again, go down by 5. Heart rate less than 100 again, go to 0. But yeah, you do have 3 other patients. It's harder to manipulate as much as in the ICU. But anyways, it's 5, 10, or 15. If you're at 2.5 of cardizem, that's weird. Well, how'd you get there, right? So sometimes they might need just a little bit of low dose, right? And that's something you have to change the default order for, right? Because the default order says this, right? You come in and you get a report on patient diltiazem, you expect to be 5, 10, or 15, right? 15 means you require a lot of support to bring the heart rate down. If the heart rate's like 150, it's like, well, shoot, maybe cardizem's not working. Or like, when did you start it, right? I just started 5 minutes ago. Okay, let's give it a chance to kick in. And if it's not kicking in, then we have to switch to something else, right? What can we switch to? Well, does amiodarone work on the atria? It does, right? So it works on atria and ventricular rhythms, right? So we can use amiodarone to decrease the tachyarrhythmias that may be happening, whether they be ventricular or supraventricular. So it works on AFib, A-flutter, PSVT. It also works on VTAC, VFib, and torsades, right? So it works on ventricular rhythms and atrial rhythms, right? So it's going to prolong the QT. That's how it does its thing. It blocks potassium channels. It's going to, make it so less impulses get through in the end, right? So it makes this cardiac action potential a little longer, so less impulses are able to get through, right? From there, compared to the baseline, right? So before we were getting 2 extra impulses through, with amiodarone, we're gonna expand it and get less impulses through, hopefully, abating event VTAC or a flutter or a fib, whatever it might be, all right? So that's how amiodarone is going to operate. And you give it like a bolus, just like our diltiazem, and then you give a infusion. And the infusion, this can be given on tele. This is it's not really titratable. It's just you got to make sure you titrate it down once, right, and then down off, right? So you start it at 1 per minute, right, for 6 hours, and then the rest of the 24 hours. So 24 minus 6 is 18. The next 18 hours is going to be 0.5 for 18 hours. Sometimes you'll come in, you'll get a report, and the patient's on 0.5 amiodarone. That means it might need to be turned off on my shift, right? So you have to pay attention to that. If your heart rate's still like 140s, like, do I turn it off? What do I do, right? So you might have to continue the amiodarone at that point. We have to continue the antiarrhythmic until we're good and ready, right? Until the heart rate's controlled. We have to add other things on there. We have to figure out why they're getting tachycardic. So this is only controlling the symptoms of tachycardia. It's not actually controlling the underlying problem that might be causing the tachycardia. Okay, so the side effect for both of these are going to be bradycardia, obviously, right? So we have bradycardia for both, hypotension for both, right? So if they're really hypotensive, like the blood pressure is like 80 systolic, and you have an AFib RVR in the 150s, can I give amiodarone? No, you're going to drop the blood pressure too much. So I need to start a vasopressor in the meantime, right? What vasopressor do I want to start? Pure vasopressor, like vasopressin, maybe, but usually we'll start phenylephrine, because vasopressin usually is not by itself. Usually we'll do like phenylephrine first, right? And get their blood pressure under control. If you really truly think that the AFib, RVR, or the tachycardia is causing the low pressure, we can shock them out of it. So we can do a synchronized cardioversion, right? And they might not need a medication in the first place, right? But if we're going to start a medication, we know that that's what we want to start. We need something to support our blood pressure first. And as we mentioned, it can prolong the QT. So our QT gets prolonged and prolonged and prolonged, and that can lead to what? Torsades. And isn't amiodarone for torsades? It is for torsades that's caused by electrolyte problems or ischemia or such. But if the torsades is caused by prolonged QT, we're probably not going to choose amiodarone, right? All right, so before you discontinue, though, you got to make sure you verify that, hey, do you want to start anything else before we take away this drip? Because if this drip's going to stop, and then I'm going to be without anything to support their or suppress their AV node or suppress their extra impulses, right? So it's up to them to decide which one we want to, if we want to just let it ride and see what happens, YOLO, right? Or we do want to, let's start stuffing PO in the meantime, right? So it's really common with diltiazem. They'll start, come off the diltiazem and start stuffing PO diltiazem, right? And usually there's overlap here. So the overlap occurs so that we get the medication to kick in, right, for 2 to 4 hours, and then we'll titrate off the IV infusion. So switching gears to anticoagulants. So these are also medications that can be given outside the ICU, but you'll see them in the ICU as well, right? All anticoagulants are independently double-checked. Every single rate change, every single bag hang need to be independently double-checked. So with our diltiazem, do you need to get a witness if you go from 15 to 10? No, that's on you. All right, that's what you're trained for right now. That's what you know how to titrate up and down on diltiazem, right? But if it's heparin, you're going from 30 units per kilo to 20 units per kilo. Do you need a witness? Absolutely, right? You need a witness to have them to verify the PTT is correct, and they have to co-sign that I agree that's correct, and I agree this is what the pharmacy's recommendations were, right? So heparin is one of our agents, and argatroban is one of our agents. It's for patients who have a heparin allergy. That's a fancy name for that is heparin-induced thrombocytopenia, or HIT. Right, so we have argatroban in those situations. Otherwise, both of them follow the APTT, and they will be then titrated based on that. Right, your APTT is how long it takes to get from point A, or APTT, to point B. Right, so how long does it get from here to here? It should take about 10 to 12 seconds, or I'd say about 12 to 18 seconds, is how long it takes for you to stop bleeding, right? That's your normal coagulopathy. If I slice your thumb open right now, it'll take about 12 to 18 seconds to stop bleeding. Depends how deep I cut, right? But either way, that's how long it should take. If I'm on heparin, it's not going to take 20 seconds anymore. It's going to be almost 2 to 3 times that, or 1.5 to 2 times technically, right? So it's about 40 to 68, somewhere in there. That's a therapeutic range. They found that that's the sweet spot to prevent further clot buildup, right? Because how do you get a clot? You get a clot when you activate the coag cascade, right? So we're going to slow that down so that we don't develop further clotting events, right? Whether it be a PE or an MI or a DVT, whatever it may be, right? So we're slowing down this, and we're monitoring the APTT. It keeps disappearing on me. What's going on? All right, so APTT is what we monitor for both these agents. If you're fancy, the lab can draw a 10A level on you. 10A is a central element of our coag cascade. It's the linchpin. It's what is the common pathway between the external and internal pathways, right? So that is a central area that we can measure, hey, what's the activity of that 10A enzyme, right? It's called 10As, right? It converts 10 to 10A. So we can look at that as well. And our 10A inhibitors are like our apixaban and such. That's exactly where they work. They're very, very specific, and that's why you don't have to monitor levels with them, but you do have to do with heparin, because heparin, blocks out this one, a little bit of that one, all this one, that one too, a little bit over here too. So heparin is like a shotgun approach. Not as bad as I'm about to say warfarin, about as rat poison. It's not as bad as that one, but it is definitely going to make your coags longer. Okay. So that's what we do for these ones. You're monitoring APTT, and it's protocolized, and pharmacy is the one who's titrating, not you. All right? You are just verifying that what they did was correct. Also, when you're on heparin, sometimes they're on for high dose or for low dose. So we got to make sure we have the right heparin order set as well. All right, so inotropes. These are your inodilators. Because we have inotropes that are inopressors, such as which ones? Digoxin increases inotropy. It doesn't really vasodilate. Actually, vasoconstricts a little bit. But what's an infusion that we give? That's an inopressor. Nope. Dobutamine is an inodilator. Dopamine is, right? But our norepi and epi are inopressors. They're going to vasoconstrict, and also they're going to increase inotropy. Which one does it best? Epinephrine does it right out the gate, whereas norepinephrine will do it a little bit later, higher doses. Whereas alpha-1 first, then beta-1. Whereas epinephrine is alpha-1, beta-1, beta-2, beta-3, all at the same time. Okay, so these guys work a little bit differently. So they're going to have, they're going to increase inotropy, but they're also cause vasodilation. So dobutamine is a poor man's milrinone. If you can't afford milrinone, then you're going to be on dobutamine, right? So dobutamine, it sounds like dopamine, and it has the same side effects as tachyarrhythmias. So it's also going to start raising your heart rate, right? It's stronger than dopamine as far as inotropy is concerned, but it's definitely going to cause a side effect of increased heart rate, right? That's one of your side effects there. All right, so tachyarrhythmic. So it has beta-1 properties, which we know increases heart rate, but also beta-1 increases inotropy, so which is nice, right? So it's beta-1 first, then beta-2, then alpha-1. So dobutamine, like at more than 15 mics, can cause vasoconstriction, so it can be used as a last-ditch effort, but really we're using it for its inotropy purposes, right? So it's usually at fixed doses, right? So we start at 5, we go up to 10, go to 15, sometimes we go by 2.5s, right? So 2.5, 5, 7.5, and we look to see if there's good outcome, right? So if you're like starting on telly, you're in the dark. It's like, I don't know, maybe it'll work better, right? So they maybe assess the patient, they were in a poor output state, they had rails in their lungs, they had cool extremities. We started dobutamine at 5 to see if it works, right? Same thing in the ICU. Started dobutamine at 5, see if it works, right? I don't know if it's going to work, but it might work. The best way to know that it's working is to get a cardiac output from a PA catheter. Then you know exactly how to titrate my dobutamine, right? I get my cardiac index goal is say 2.2. So my cardiac index is 1.5. I'm going to start dobutamine. And look at that. It went up to 1.8. And you're going to let it ride for like an hour or two. It's like, well, it's not moving, so let's go up to 5 and see if that increases my cardiac index to like 2 or 2.2 even. All right. So that's the idea behind dobutamine, right? PA catheter is usually in place if you're going to be titrating it. Otherwise, the cardiologist will just start like at 5 mics, right? What else? So milrinone, right? So milrinone is a PDE3 inhibitor, kind of like Viagra, right? It's going to be working on the vessels to vasodilate like Viagra does, but it's also going to work on this enzyme which is found in heart muscles, right? This is not found in the penis. PDE5 is found in the penis, right? But PDE3 is found in heart muscle. Also, it's found in some vasculature, but it's going to inhibit this muscle. This enzyme right here, and this enzyme actually breaks down CAMP. And what does CAMP do? CAMP causes contraction. So do we want that? Yeah, let's get more PDE3, right? Or do we want PDE3? I don't know. What do you think? We want CAMP around, so let's start blocking PDE3, right? So we're going to block the PDE3, so we have more CAMP activity, more contraction, more contractility, more inotropy. But if you look at PDE3 and the peripheral vasculature, it's actually does the opposite effect, right? PDE3 over here causes the relaxation of the vessels, right? So I give a prostaglandins, which kind of stimulate this whole process here, and norepinephrine, epinephrine, etc. They make CAMP, right? And CAMP's going to inhibit it. So you notice that it's a reverse action compared to on the heart, right? So it has a long half-life, which is an important thing to think about. With dobutamine, half-life's got 30 minutes or so, but with milrinone, it's 4 hours. All right. So once you start milrinone, you can't take it back. So you really got to make sure that it's what you want, right? So that's why having a PA catheter can definitely help to assess if we need to have a infusion of this medication to raise someone's contractility or not, right? Because we know it's going to lower their blood pressure for the next 4 hours at least, right? So we want to make sure we have something on standby in the meantime. So usually we have like norepinephrine going, and then we'll start our milrinone, right? That way we have those guys working together. All right, and then the other piece about milrinone is it's great at reducing PVR, or pulmonary vascular resistance, right? So it's definitely going to vasodilate the periphery, but it's also going to vasodilate my pulmonary arteries. If I have pulmonary hypertension, that's not due to left heart failure, but also due to someone who has like this chronically sustained pulmonary hypertension. Okay, so that's the idea behind milrinone, right? Milrinone is a great medication for increasing inotropy, also great medication for pulmonary hypertension, right? We have other medications out there like our prostacyclins and our nitric oxide, which for pulmonary hypertension, but you can see milrinone's over here to help maintain vasodilation. Okay, so CAMP, this enzyme, this protein that's in many cells, right, on the heart. When you have CAMP activity, it vasodilates the coronaries and it causes inotropy. Perfect. In the periphery, though, CAMP, when it's more active, causes vasodilation. So it has like an inverse reaction. It's not exactly related to SNS or anything like that. It's its own little thing. Okay. So the other thing about milrinone, they tried doing PO milrinone because people are usually on IV pumps at home, but PO milrinone causes like cardiac arrest and such, so it's not great, right? So they want to make sure. So IV is the only way they could give it. All right. So then GI bleed drips. So we're switching over to the GI tract, and we'll have a whole section on GI bleed, a lot of GI bleed and GI lecture, but these are the drips that you're going to see over there that we're going to kind of circle back to. So Protonix drip, no better than just PPI BID. So if you're on a Protonix drip and you really are strapped for IV access, this is the one that you can let go of, right? So, hey, can I take this off? I'm going to give Protonix, right? BID. Sometimes I'll do a little loading dose of 40 or 80 IV push, then give the 40 BID, but it's no different than just giving than a drip form versus the BID form, right? But if it is a drip, it's fixed rate, right? It's just infusing at a fixed rate until we're done, right? And usually when we're done, we're transitioning to PPIQ 12 hours anyways, right? So you could have started there in the first place. All right, so what else? So octreotide, or sandostatin is another name for it. Octreotide is a GI suppressant. It just shuts down the GI tract, right? It's going to vasoconstrict. It's going to slow down, peristalsis. It's going to stop the pancreas from secreting insulin. So, and if that's the case, or if I got sandostatin over here, it's going to inhibit insulin release. That's going to raise my blood sugar, right? So it's also, sometimes it's used as a last-ditch effort to raise someone's blood sugar, right? So if someone's really hypoglycemic, can't figure out what's going on, we can use octreotide for that. But the most common reason you're going to see it is for someone who has a GI bleed. So if someone's bleeding and hemorrhaging, we're going to be giving octreotide to clamp down, right? Vasoconstrict, stop the secretion of acids, right? So we have our sandostatin here also inhibits gastric acid production. If we know we have a peptic ulcer that's being eaten away by the gastric acid, we definitely want to stop the gastric acid from being released. So that's what sandostatin is going to do. It's going to shut that down, right? It's also going to vasoconstrict, so you have less blood supply to the gut as well, right? So it reduces blood flow. It does all these things that are going to help a GI bleed that might be occurring, right? So we got sandostatin and we got Protonix. Now, if your Protonix is great for a peptic ulcer bleed, right? Because Protonix works right here, works right at the spot where hydrogen is being secreted into, hydrogen ions are being secreted into the gastrum, right? Whereas something like histamines, like why don't I give histamines? Like histamine, yeah, it works over here, but you still got muscarinic antagonists. You still have steroids that work over here as well, right? Steroids. There we go. And you still have gastrin. You still have all kinds of other things. It's only 25% effective if you give histamine. If you really want to stop someone's gastric acid, you're going to be giving Protonix, right? And people thought, well, Protonix strip, go straight to 11. That's what we need. But really, they found out just BID is just as good. Okay. So octreotide is going to vasoconstrict. So it's really good that someone has portal hypertension. So usually, if they have a variceal bleed, they'll do sandostatin. If they have a peptic ulcer bleed, we'll do Protonix. If we don't know, it's just GI bleeds, we're doing both, right? So they're going to be on both. If they truly have a GI bleed that's squirting out, then we can then get a titratable vasopressin. So vasopressin is usually fixed dose for septic shock, but if it's a GI bleed, that's when we can start titrating it up all the way to 0.1 is usually our max on that guy. All right, so antihypertensive drips. So these guys are our medications are switching completely to the other side. We're always talking about hypotension and shock and everything else. This is the other flip of the coin. So this is someone that is very, very hypertensive, right? So we're going to give antihypertensive drips, all right? So remember that off switch that we talked about, like the alpha-2 off switch? Yeah, you can start some PO agents to get their blood pressure under control, like clonidine can work there. But usually what we're going to be working on is just the vasculature itself. So nicardipine is just a calcium blocker. But wait, I thought we talked about diltiazem. Was that a calcium blocker also? So yeah, you got DHP and non-DHP. DHP is like the little doorbell that's on the muscles. And if you inhibit that muscle, then all muscles are going to relax, right? So we're inhibited directly there. Whereas like diltiazem, it works on the cardiac action potential. It works on the calcium channels within the heart itself, right? Compared to nicardipine, as a DHP calcium blocker, it's going to vasodilate everywhere, right? And it's going to be useful for someone that has hypertension, right? It's nice because it is it's going to bring it down like we expect, but it has an overshoot, right? Once you start it at 5 and go up by 2.5, so you keep going up and up and up, right? You can sometimes overshoot it, right? It's like a big Mack truck, right? Like you're going to get going, you're going to go, and you're going. It's like, oh, look, my blood pressure is 160, perfect. And now it's 140, and now it's 125, and now it's 115. So you got to, usually you have to expect that it's going to overshoot. So usually once you hit your target, you're going to kind of back off a little bit to get your, make sure your blood pressure is not going to be getting too low, right? Because as we kind of touched base on in hypertension, you want to bring down your blood pressure nice and steady when it's really, really hypertensive. You want to bring it nice and steady about 25% every 24 hours, right? Unless, little asterisk, if you have TPA, right, or TNK, or if you have aortic dissection, or you have a trauma, right? In those cases, you're going to bring it down much more rapidly, right? Just different targets, like 185 for TNK, and for a bleed in the brain, you're going to take it down to like 140 to 160, and for like traumas and aortic dissections, all the way down to like 80 to 120, somewhere in there. Okay, so the side effect though with our nicardipine is overshoot hypotension. It can overshoot it, right? And it causes reflex tachycardia. So what we're doing is we're vasodilating all these peripheral vessels. All these peripheral vessels in the GI tract are all vasodilating. And now less blood flow is returning back to the heart, and less blood is being pumped up against these little baroreceptors over here, right? So it's like, what the heck? Why is the blood pressure low? Right? And what's it going to do? It's going to fire off the SNS to the brain and tell it to raise the heart rate. That's called reflexive tachycardia. Okay? So it's going to reflexively cause tachycardia. Does it cause tachycardia when I infuse it? No. It causes it when I overdo it, right? When I have overshoot hypotension. Now there is another agent. It costs money, right? So there's a lot of money with clovetapine. It is a newer agent. By newer, I mean like 12 years. So it's an agent that it doesn't have this overshoot, right? But it's very, very difficult to it only lasts 10 minutes compared to like 1 to 2 hours, right? What else? So we have nitroglycerin. So nitroglycerin, we know we give for like MIs and such, for like, sublingual nitroglycerin. It's doing the same thing. It's vasodilating this periphery, and it's vasodilating the venous side. So it dilates on both sides. So that's definitely going to reduce the amount of flow back to my heart and help a heart that is overloaded with preloads, right? So that's going to, help someone. It's also going to vasodilate, I should say, the coronary arteries, right? So the coronary arteries are also going to dilate. So that's going to improve flow for chest pain, right? It's going to definitely help someone who has chest pain. It's going to improve flow to the coronaries. And then if we have someone just hypertensive, it's going to vasodilate and push all the blood out into the periphery. It's going to induce a vasodilatory shock. So vasodilation is one of our goals, especially when we have a patient that's in CHF exacerbation, someone that is in fulminant CHF, pulmonary edema. We want to open up the valves on the other side so the fluid can actually move forward. Whatever function our heart does have, we want to vasodilate, and then we're going to hit with a 1-2 punch, and we're going to diurese them at the same time, right? So you give them like a nitroglycerin infusion. We're also going to throw some BiPAP on them just for good measure to push all the fluid aside and help push the fluid in the periphery that we vasodilated. And that's going to help unload the heart, right? That's called SCAPE, or sympathetic crashing pulmonary edema, acute pulmonary edema. So that's a flash pulmonary edema, you might have heard it been called, but that's something that we could be used in someone that is in distress, right? This is a great medication when you have someone who has chest pain and hypertension. Well, shoot, I got the perfect thing for you. It's going to help your chest pain. It's going to help your hypertension, right? So the dose is like 5 micrograms, but they can go by Q5 all the way to 400. That's going to take you a couple hours to get all the way to 400, even more than probably a whole shift to get all the way up there. So once you start hitting like 100, 200, it's not going to be effective. You don't have to like go all the way to 400 for like, it's not working, right? So usually by 100, 200, you're going to find something else, right? So we just have the nitro like at 50 mics, and then we can start cardine, right? Nicardipine to support the blood pressure if we need to. Side effects, it's going to vasodilate not only the coronaries and the venous side and the arterial sides, and also dilate the head, right? So you're going to get some headache, all right? But as we mentioned, it can develop tolerance very, very quickly. There's a difference between tolerance and tachyphylaxis. Tolerance means it takes the medication, you have to keep giving it, and they might be able to have the same effect. But in tachyphylaxis, with time, they just have no effect. Right? The effect just goes down over time. The response goes down over time. All right, other agents, labetalol, not as a IV drip, but IV push for sure you can give. Esmolol is an IV drip, right? It's pure beta blockade. Obviously, they can't have an AV block if you're given a pure beta blocker. And it's usually for someone you want to bring down the blood pressure immediately, like a patient who has what? Yeah, so hemorrhagic stroke maybe, but nicardipine is good with neuro. But like definitely aortic dissection or trauma patient, you're going to bring that blood pressure down immediately to stop the bleed from bleeding. Okay, and there's our nitroglycerin. Right? You might have heard nitroprusside. Please don't give nitroprusside. Nitroprusside gets toxic over 3 days, especially if they have renal failure, and it has a half-life of like 30 seconds or something. It's ridiculous. If you're doing like a bed bath next door and your nitroprusside runs out of it starts beeping at you, you got like literally a minute to fix it. Otherwise, your blood pressure goes sky high. But it can be used if we have contraindications to these guys.